So again, like I mentioned, I'll talk a little bit about the features of people on the FASD continuum, but I'll probably run through that relatively quickly. So if I skip over something you're interested in, please shout out. So these are just some photos of kids and young adults who are on the continuum. Some have obvious facial malformations, some not. I talked about diagnostic criteria, right? So for FAS, fetal alcohol syndrome, these are the criteria. In particular, the facial malformations. Alcohol primarily affects midline structures. That's why you get the loss of the fulcrum, the receding chin, the eyes being wide apart, and other features, thin upper lip, and lower set ears. And what's interesting in fetal development, your ears actually start in the middle of your face, which is why they're affected by prenatal exposure to alcohol and why you get the low set ears, okay? So for FAS, you need confirmed or unconfirmed history of exposure and category 1, growth retardation, prenatal or anytime after birth, facial malformations, and neurodevelopmental disorders, cognitive impairments. For ARND, confirmed or suspected history of prenatal exposure, coupled with measurable developmental delays, including cognitive impairments. Okay. And again, I'm not going to go through this, but for FAS, these are the features that can be affected. Here's a picture of an infant with all the features that you see typical of FAS, the epicanthal fold, the flat nasal bridge, the upturned nose, loss of the fulcrum, thin upper lip, lower set ears. See how the top of the ear is below the eye? And if you just take a moment, if you'll see your ears, for most of you, the top of your ears is above your eye. Okay. So see all that. And again, just some more pictures, adults, children. It's fairly prevalent. Less so now than, say, 30 years ago, but nonetheless, there still is a fair amount of children born with prenatal exposure to alcohol and other toxins that can have a pretty significant effect on development. So 11% of all newborns have been prenatally exposed. Not all of them will have difficulties, but a high proportion will. So, even if we're only half that were negatively affected, that's a lot of newborns. Okay? That's more than are affected by spinal bifida, for example. Okay? And then just some statistics from New York around, and probably these are pretty comparable to what you'd see in other parts of the country. Half of the children placed in foster care had been prenatally exposed to cocaine. Okay, that's a lot. Okay. Children born to birth mothers who've been abusing drugs are much more likely to be physically abused. So you've got the prenatal exposure and all the problems that creates, coupled with all the problems that are created by being a victim of physical abuse. Okay. And again, looking at infants entering foster care, half have been drug exposed. Around a third have growth failures, failure to thrive, born prematurely, have different developmental delays. And Nearly half have behavioral problems compared to maybe 3 to 6% of the population who weren't prenatally exposed. And again, developmentally delayed, half showed developmental delays, children in foster care, compared to 4 to 10% in the general population of kids. Children adopted from foreign countries are even more likely to have these problems. In Eastern Europe, what we know is the average rate of alcohol consumption in Soviet Russia and Eastern Europe is 3 shots of 100 proof vodka a day. That's average. Okay? So some people drink more. Certainly the people who have their children removed or who abandon their kids drink more. So there is a high likelihood that a child adopted from Eastern Europe or the former republics of the Soviet Union have been prenatally exposed to alcohol. I just put this chart here to show how different parts of the body are affected by prenatal exposure to alcohol, depending, on when the exposure occurs. So, hypothetically, if the exposure didn't occur until week 25, the heart, the arms, the legs, the palate, the ears are not likely to be affected, but the eyes and the brain is. In fact, the brain is likely to be affected at any point through gestation as a result of prenatal exposure. And as any pediatrician would tell you today, there is no safe level of exposure to alcohol. Best just not to drink if you're trying to get pregnant, think you're pregnant or are pregnant. And risk factors. Well, there's the dose. There's the pattern of exposure. So for example, binge drinking is worse than chronic drinking. So not that you would recommend this, but it would be better to have 1 beer a day than on Friday night have 7 beers. Okay. During development, when is the exposure? The genetic variations. Some people are much more, because of genes, may be more susceptible to it. This is why among fraternal twins, you may see one twin much more affected than the other twin. Because while they're twins, they're fraternal. They don't have identical genetic, they don't have the same genetics. And then, of course, are there other toxins that the fetus has been exposed to? Lead, drugs, cigarette smoke. Okay. All right, so effects on development, just to kind of skim through that. First of all, one thing to think about is the way we process information involves 4 elements: input, integration, memory, and output. And any and all of those can be affected by prenatal exposure to alcohol. So for example, one of the areas I see often most impacted is memory. And memory is composed of 4 different components. You have working memory, right? So I say to you, what's 29 times 2? Well, you can do that in your head, 9 times 2, that's 18, put an 8 down there, carry the 1, et cetera, et cetera. And you hold all that information in your head. That's working memory. Or I give you a phone number. Hey, I'd like you to call this number. I tell it to you, you pull out your phone, you dial it. Today over dinner, I say, hey, what was that number I told you to call? You're probably not going to remember. Working memory is, pretty ephemeral. Then there's short-term memory. So we go over the multiplication tables. You get them now today. That's short-term memory. If it doesn't make it to long-term memory, And that's often where we see notable impairments, is the moving memory from short-term to long-term. This is why you hear parents sometimes say, you know, my kid had a math test on Monday, so Saturday we went over everything she was supposed to go over. You know, took a little work, but she nailed the multiplication tables. She understood about division. She got fractions. You know, she was going to do well on this test. Then they get the test back that she took on Monday, and she failed. And sometimes parents will say, I don't get it. Why does she pretend to be stupid? She's not a stupid kid. No, she's not a stupid kid. But what's impaired is her capacity to move information from short-term to long-term memory. And so for kids who've been prenatally exposed, where that is an issue, they need much more repetition than your more typical kid. So, you know what that might mean. You go over the math stuff on Saturday, Sunday, you do it again. You see what they didn't remember. You drill, you go again and again and again, and then they're probably going to get it. And then hopefully that information eventually moves from long-term memory to permanent memory. I'm not going to talk about this particularly. Epigenetics. Epigenetics is basically the field of looking at how experiences affect genetic expression. So it's not nature, nurture. Environmental factors affect whether genes will be turned on, turned off, or to what extent they'll be active or inactive. Okay. Well, I'm not going to go through how that actually occurs. It's just enough to know that piece. And I put this slide up here just to illustrate how complicated information processing is. And there's so many points here where brain damage can really affect how memory and how information is processed. So, you know, we take in information in our ears, we hear it from our body and visually, and that information, like visual information, has to go to memories. You know, we call up certain memories, perception memories, and that then moves into plans for movement or action. Okay, so lots of places here where that can be affected. One quick thing to show, you have two hemispheres, you probably know that, and they're connected by this very thick bundle of nerve fibers. The two hemispheres are connected by this, called the corpus callosum. So it's, you know, it's like it's like sort of the wiring for the internet. It connects everything. And the more well-developed the corpus callosum is, the better the communication between right and left hemispheres. And they do function somewhat differently, which makes sense. You don't need two things that do the same thing. They operate somewhat differently and process information differently. So the right hemisphere tends to process information more globally. When there's emotional components to the information, that's the part of the brain that seems more active. The left hemisphere tends to process information in a more linear manner. That's where your speech centers are. Okay. And here's another picture of it. And here's an example up here is kind of what the corpus callosum ought to look like. Here it is in a child who was prenatally exposed to alcohol. And as you can see, it is very small. And that's going to create significant impairments. Now, for kids who have ARND, it's unlikely that X-ray or MRI is going to be particularly definitive because the effects are so minor, but they do, cause difficulties. Okay. That. And then I'm not going to go through each of the different parts of the brain in detail. If you want me to, I'll go back. You can look at these on your leisure. The slides will be on the attached website. So I think you can look at them or download them. But what I have here are just the different parts of the brain, what they're supposed to do. And so you can see how, if alcohol affected them, those parts of the brain, what effect that might have. It affects the frontal lobes. Impulse control may be affected. Right. We talked about the corpus callosum. So the primary disabilities that we often see with prenatal exposure to alcohol are lower IQ, and it may still be in the normal range, but it's lower, than it would have been. Often there's impaired ability in reading, spelling, and arithmetic, and lower adaptive function. Okay, and that's often more impaired than IQ, and that's something you can get from the Vineland adaptive behavior scales. There's a whole section on adaptive functioning.
Can I ask you another question, quick? Sorry, I walked in late.
No, go ahead.
Already, and I'm doubling up. But do you ever notice? And I'm thinking about my students right now. I work in an elementary school primarily. Do you ever notice higher levels of IQ but lower levels of EQ? Essentially, I mean, I know that we're looking at primary disabilities, and not all of them are going to look the same. But do you notice a big difference? Do you notice a lot of mostly lower IQ, or do you see a lot of kids that still do have the high IQ with the low ability to control their emotions? Because that's what I've noticed. I'm thinking about a student in particular, super smart. He's fetal alcohol, but his ability to manage his anger and is so significant. So when I look at the lower IQ and stuff, I just wonder what your experience is with that and what your thoughts are.
Well, IQ may be affected. Primarily, it's affected in relation to what could be. So that's a little bit, I don't know how you measure. Oh, well, the kid would have had 130 IQ if, his mother was drink, but now he only has 120 IQ. Yeah, I mean, you can't measure that. So alcohol can cause lower IQ or not. Again, it's a continuum, and you can't say, well, the birth mother drank this amount for this period of time, therefore here's what we're going to see as a disability. You can't. It's so variable. But alcohol does have notable negative effects, brain damage, in or on the limbic system, which is the part of the brain responsible for emotional processing and impulse control.
So are you talking about like the frontal? Is the limbal the same as the
frontal? No, the limbic system is, let's see if I have.
Because we've learned a lot in this training about the prefrontal cortex and the amygdala.
Well, the amygdala is not in the prefrontal cortex. The amygdala is at the tail end of the.
Yeah, but I mean, as far as behavior-wise, I've learned a lot about the amygdala and then the prefrontal cortex, and I'm wondering when you talk about the limbic, if you could explain a little bit more about that.
So, as I said, the limbic system is responsible for emotional processing and impulse control. The prefrontal cortex also is involved in impulse control, primarily because the orbital frontal cortex, the part of your brain behind your eyes, is a major switching center, so to speak, connecting the prefrontal cortex with your limbic system. So if that's impaired, if those neural pathways that connect the limbic system through the orbital frontal cortex to the prefrontal cortex, if those are impaired in any way or diminished in any way, then your ability to bring to bear your prefrontal cortex will be, impaired. It's like, is the pipe small or big? If the pipe is tiny, things go slow. If the pipe is large, it can carry a lot of information. Also, this is a good time to make the point. A child who's impulsive might have been prenatally exposed to alcohol, or could have ADHD. ADHD, attention deficit hyperactivity disorder, is primarily a disorder of the prefrontal cortex, specifically an immature prefrontal cortex, which is why, say your 6, 7, 8-year-old who obviously has ADHD might not show many symptoms by the time he or she gets to college, because your brain isn't fully integrated until the early 20s. And so symptoms of ADHD tend to dissipate as the individual matures and as the integration of the different brain systems improve or increase over time. So you're born with all the parts of your brain, but it takes a long time for all the different pieces to connect with each other. So ADHD is a disorder of the prefrontal cortex, kind of an immature prefrontal cortex, and that's why stimulants work so well. So, for example, that's why stimulants are traded on college campuses, because they'll help anybody with attention. Impulsivity, maybe, maybe not. Alcohol primarily affects the limbic system, not so much the prefrontal cortex. Stimulants for those individuals are likely either to have absolutely no effect or to even make things worse. And the medications that target the limbic system around impulsivity are things like clonidine, Tenex, and Intuniv. They're largely blood pressure medicines. So in some ways, they're, I don't know if this is the right way to describe it, but in some ways they're better than a stimulant, because stimulants can affect your appetite, they can affect your sleep, and they can retard physical growth. The blood pressure medicines have none of those effects.
But those meds are used sometimes for ADHD as well, right?
Yes.
Yeah. Okay. So, oh, now I have so many questions, but I won't get into it because that's a whole other topic. I wish I could talk to you.
The main difference is that, yes, they are sometimes used, but again, often kids with ADHD, the concern is more the attention, so they're given a stimulant, but it turns out if they don't really have ADHD, this is when I hear from parents.
Yeah.
Yeah, we put them on Ritalin, and or more often, which is really disturbing to me. Yeah, he takes Ritalin or something like that. How long has he been on it? About 4 years. Do you notice a notable change in behavior? No, not really. And then I always have to ask, well, why do you keep him on it? Well, the pediatrician said we could. And, my son's a physician, so I've certainly learned through experience. Physicians are not all knowing. Funny story. I think it's funny. When we adopted my younger daughter from China 26 years ago, something like that, and we brought her home. She was 6 months old. And the pediatrician had some concerns because she was at the 5th percentile height and weight. But then he said, but she's staying on that growth curve, so I wouldn't worry too much, but we really ought to monitor that. And I don't know, I'm just, I'm curious, and I went online. It turns out there are different growth charts for Caucasian infants than for Asian infants. On the Asian growth charts, she was at the 50th percentile. So I gave that to the pediatrician. It was funny. His response was, I think I knew that. I must have forgotten. So you know, when I hear, no, it's not working, it worked for the first 2 months, it stopped working, then I think, yeah, we really need to do an assessment, because yes, your kid may be impulsive, your kid may have attention problems, but why? You know, an ADHD may not be the cause, maybe something else.
Do you find that they use quantity, tenets, and intuitive for the hypervigilant behaviors of kids with trauma then too? Do you notice?
It's really more useful for the impulsivity. It kind of adds that that extra half second of pause. The hypervigilance, you know, is related, I think, more to the internal working model that develops when you've experienced chronic early maltreatment in a caregiving relationship. You know, that internal model you have of the world is that, you know, this is a dangerous place. People can do things unpredictably and randomly. And so, you know, this is a good example of, I find it useful to think of symptoms and try to figure out how they were adaptive, because all behavior is adaptive. So if I'm living in a world where people can be, you know, unpredictably hurtful, violent, dangerous, if things happen, you know, out of the blue, well, being hypervigilant is a pretty smart thing to be, you know, wouldn't you say? Now you put me in your home, which is a nice, normal, good home, and all of a sudden I have a symptom. Or another good example, if I'm being raised in a home with people who are alcoholic or drug addicts, so I'm being neglected, not physically abused, but neglected. So, you know, things like food isn't always around and things, you know, stuff like that. So then I would learn, well, you know, going through dumpsters and garbage cans, I can find food. And when I do have food available, I better gobble it up, because who knows how long it'll be around. And if there's some extra, it's probably a good idea to put that under my pillow at night, just in case. Now, again, I go to your home, nice home, well stocked with food, no problems. And now you bring me into the therapist, because why? Because I'm always hoarding food. And when I sit at the dinner table, you know, I scarf all the food down. I have no manners, right? And I have a symptom in your home. But when I was in the other home, that was pretty smart stuff I was doing. Okay. So, and again, some typical areas, sensory integration issues are really common with kids who've been prenatally exposed to alcohol. So that's why I always want to look at that. And then just something, kids who are on that continuum generally are overly sensitive to sensory inputs. See, and that in and of itself can cause hyperactivity or impulsiveness or hypervigilance. And if I can't screen out what I'm seeing and what I'm hearing, and it's all coming in at me, right, I'm probably going to be somewhat impulsive and maybe, you know, hypervigilant, because I'm hearing and seeing all these things that ordinarily people can get rid of.
Looks a lot like ASD.
Yeah, it can. And again, I sometimes see kids, parents come in, well, the teacher thought, you know, my kid, you know, might have autism or might be on that spectrum. And I, you know, find out, well, no, that's the thing I always first ask is, have you brought them to somebody to get, you know, who's an expert in autism, to get the, what is that called? To get the ADOS, Autism Diagnostic Observation Scale. And if that hasn't been administered, then I don't take the diagnosis of being on the spectrum as being valid. Okay, you have to use the right test. Some kids are just, you know, to describe it, some kids are just odd. They're just, and they are, and they're just odd, and that's fine. There's nothing wrong with them. They're just, you know, a little bit unusual.
Yes, I know, is it?
I should be.
Odd disorder.
Yeah. So what we see is kids who've been prenatally exposed, they can be overly sensitive to sensory input. Sensory profile is helpful here. Upset by bright lights or loud noises. You know, so again, think about the kid walking in recess, and the kid comes up behind them and, you know, yells something, and the kid turns around and slugs them. Well, are they overly aggressive? Well, yeah, that's probably not a great response. Or are they just like, you know, fight, flight, freeze, responding to this overly loud sound? Okay. Might be annoyed by tags in the back of the shirt. So again, these are kinds of things that may co-occur to a child who's been prenatally exposed. Talked about problems with working memory. Multiplication is an area, and subtraction is another area where you often see this. Time sequencing, somebody mentioned earlier, is another problem you see. So for it, again, it's really interesting. You have I don't do IQ testing, but you know, you do an IQ test and find, oh, hey, this kid, you know, he or she can put things in alphabetical order reasonably well. And she knows where the numbers go and can put them in order. That's another kind of sequencing. But when you show a series of pictures, she gets confused about, should the picture of the boy carrying the vase come before or after the picture of the broken vase? 3 different kinds of sequencing. 1 or 2 may be impaired, but only 1 may be. This is where a good, thorough neuropsychological evaluation by a board-certified pediatric neuropsychologist can be helpful to pinpoint what are the strengths, what are the deficits. We'll talk more about that when we talk about treatment. We talked about executive functions that may be impaired. They often don't complete chores or tasks. May look like they're being oppositional, but it may have more to do with, executive functioning. Difficulty determining what they should do next. Often they won't ask questions. They say they understand when they don't. They'll nod their head. And this kind of, did remind me of something. So the kid, you ask the child to do something, they don't do it. And often, you know, a caregiver, a teacher, or even a therapist will say, well, why didn't you do that? First of all, what's the answer you get most of the time when you ask a kid, why did you or why didn't you do that?
I don't know.
Yeah, you know the answer. Why are you asking a question that you already know the answer to? The answer is, I don't know. Second of all, by a show of hands, in the last 2 or 3 years, how many times has your supervisor come into your office and asked you, why did you do such a good job on that case? When your supervisor or your partner starts the conversation with, why did you? What do you start thinking?
We're in trouble.
What I do wrong?
I like to do that with
Exactly.
my husband.
Exactly. I'm in trouble.
I like to scare him.
What did I do now? Okay. Why is a blaming question? It's a critical question. You know, while my wife and a good friend of ours is a psychologist and my older daughter is a psychologist, all say, I must have had as a kid and certainly do as an adult have ADHD. I don't agree with them, but that's a different story. Nonetheless, the answers the question before it's been finished. Sometimes I come home and my wife is as I come in the door. Why did you? I'm really sorry. I don't know what I was thinking. I'll never do it. And she says, shut up. Let me tell you what you did before you apologize. Okay. So, you know, why is a blaming question, critical question. So we're going to take a kid who already has an impaired ability to tolerate frustration and poke a stick at them. So don't ask why. It's not a good question to ask a kid. Instead, you could ask, what happened? Oh, before you did that, what happened? When this happened, what were you thinking? Okay, what was going on? Things like that. When did it occur? So who, what, when are good questions. I'd stay away from why as best you can. And of course, kids who've been prenatally exposed often have difficulty following through on multi-step directions, which is why, as I mentioned earlier, you may want to break things down. So put the clean towels away when you're done, let me know. Good. Now go to the bathroom and get the dirty laundry out of the hamper. Bring it to me. Good. Now go to the laundry room and put that in the washer. Okay. Rather than telling the kid all three things and wondering why it never gets done. So breaking it down into steps. And then other kinds of difficulties. Again, they often don't learn from the mistakes they made. Why? Because of the impairment in memory. Okay. The impairment in moving information from working to short-term to long-term to permanent memory. In addition, and this is true for everybody, when you're distressed, your ability to use your prefrontal cortex starts getting degraded. This is true for everybody. Okay, this is why, for example, firefighters practice again and again and again, you know, running into burning buildings. You know, they've got these test structures and they, you know, and they practice their skill. Well, I've had firefighters tell me, when I run into a building, it's like I'm not thinking anymore. I don't know what happens. My brain stops working. You know, how do you know what to do? I said, oh, I don't know. I just know. It's muscle memory. I teach scuba diving, and it's the same basic idea. You know, in the classes, we practice the same skills again and again every time we have a class, and I encourage my students when they're doing, you know, when you go diving, you usually take a 3-minute safety stop at 15 feet just to off-gas the nitrogen you've absorbed. And I tell people that's a great time to practice the skills, because in the moment, if you have an emergency, your thinking is going to be impaired. But if you just know what to do, you don't have to think. Okay. But kids who've been prenatally exposed have difficulty with that. When they're stressed, if they haven't had enough repetition, they don't remember stuff. And this is why, you know, you sit down with your child and say, now, when your sister grabs your toy, what is it you're supposed to do? And they'll say to you, oh, I should come to you and say, Mom, Sarah took my toy. That's right. Later that day, my sister takes my toy and I punch her in the nose. And the parent, why did you do that? You know you're, you know, well, no, in the moment I didn't know it. Late, you know, when I was calm, I knew it. But when I was threatened, put under distress in some degree, no, I could no longer access that. Okay, so those are some different areas. That's why they may seem lazy, uncooperative. So anyway, these are all difficulties that you may see. Speech and language. I'm not going to go over the craniofacial malformations. Let's see. We've covered most of this. Oh, theory of mind. That's that ability to recognize that what you know and what I know may be different, and what you have in mind and what I have in mind may be different. So the kind of classic test of that, say with a kid who's on the spectrum. So if I held up a box of Altoids, mints, and showed them to you and said, what do you think is in here? What would you say?
Mints.
Mints, yeah. You said mints. Okay. Now, if I opened it up and dumped them out and put paper clips in there and closed it and said, now, if I go out in the hallway and ask somebody there, what do you think is in here? What do you think they're going to say? Mints, right, because you recognize you know something they don't know, but the child who's on the spectrum is more likely to say, oh, they'll say there are paper clips in there because they don't, they know it, so they assume other people do. Lacking theory of mind. You see this to some degree or another, also not to that dramatic a degree, but to some degree or another with kids who've been prenatally exposed. That's the root of their missing social cues. Butting into groups, they don't realize the message that people are giving off is, we don't want anybody else here. And then I just throw this up here to point out, without treatment, without good therapeutic interventions put in place, these issues here get worse. They don't get better. You don't grow out of it. Mental health problems, right? Disrupted school experiences, okay? Confinement, inappropriate sexual behavior. All these things tend to get worse. And then secondary disabilities, if this is not assessed and treated at a relatively early age, the younger the better. Mental health issues, secondarily to the ARND, can develop disrupted school experiences, trouble with the law, all these kinds of things can develop, right? Employment problems, drug alcohol problems, secondary disabilities that develop if the ARND is not addressed early, or if it's unaddressed. Oh, okay, we're doing quite well on time. And again, this is just to show among people who have fetal alcohol syndrome or fetal alcohol effect, percentages that had secondary disabilities, okay? Over 90% of school-age kids, a high proportion of school disruption, trouble with the law, etc. And for adults, dependent living and problems with employment. Okay, so significant difficulties. It's interesting, but I don't know that it makes a difference for you all in terms of what you're going to be doing. And then we talked about some of these things already. Low growth rate, problems with brain development. Again, this is FAS, not ARND. ARND, more in the middle, closer here, but there's going to be fewer. See, the reason you have all these convolutions in your cerebral cortex, the covering of the brain, is because that part of the brain is actually much too big to fit in your skull. So it folds in on itself and, kind of gets all twisted up so it fits in, and that's where you get all these, fissures and contusion,
When you say ARND, and I know we talked about this a little bit, but I just kind of want to jump it down a little bit for
Yeah.
stuff.
Yeah.
ARND, it's like really high functioning alcohol exposure, basically. Like there are some signs and symptoms of it, but they are
Yeah.
high.
It's on that FASD continuum, but not close to the part where you have FAS. It's more toward the other end. So
Yeah.
it's the
So
same
it's kind of like
continuum.
the old version of Asperger's on the autism scale. Like that's
Yeah.
where my brain is going. Kind of similar.
Yeah, it's a good way to think about it. All right, I'm not going to talk about it. So I'm not going to go through the next series of slides. You can read. I mean, I'll talk about any of them if you're interested. But they're here. They're pretty self-explanatory, and as I said, you can get the slides off the website. But alcohol can affect all these different parts of the brain. Part of the brain more responsible for memory. We talked about that. This is the part that has to do with that. Okay, hypothalamus. So there are a variety of different parts of the brain that may be affected, right? Okay, so basal ganglia, and they can have trouble then with motor control because of that. Okay, so again, I'm not going to spend a lot of time or any time really on these. If you say, no, go back, talk about this, I will. I just want to point out that, prenatal exposure to alcohol is never good. That's all. It's just not good. It can affect different parts of the brain, some more, some less. And again, there's no way to say, well, let's see, she only drank 2 glasses of wine a week during the pregnancy, so that should only affect this part of the brain and not that much. You can't say that. We just don't know. Okay? There's so many variables. And it's interesting, people my age probably have a much higher, percentage-wise, there's a much higher percentage of prenatal exposure to alcohol. Because certainly I know when my mother was pregnant, it wasn't unusual for a pediatrician to recommend a drink a day, just, to calm down and relax.
I was actually going to ask you about that because I wondered if across generations, if there's a higher level of possibility of fetal alcohol in certain generations because it was acceptable and
exactly.
What does that look like? It's so interesting.
Yeah, so my kids are, the 2 older ones are in their mid-30s. The youngest is 26. And with the 2 older ones, I don't think my wife drank at all. Or if she did, it would have been really minor. But, at that point, I don't think we were given a firm directive, don't do this.
Yeah.
Certainly with my younger daughter, she should be delivering like imminently, that was the clear message from her OB, don't drink, period, end of story. We're done talking about it. And interesting, because after I, learned a lot more about this, I could see, my mother was not an alcoholic. She would drink on occasion. Her preferred drink was a screwdriver, right? Vodka and orange juice. And she'd have that every now and then. Well, when I grew my adult teeth, my 2 front teeth came in cracked and curved. Okay, and they had to be removed and, a bridge put in. As I've read about it, I'm convinced that's because my mother drank alcohol during her pregnancy, because that's a midline structure. And that's often you do see kids who have severe FAS, either their front teeth are really weird or the enamel on the teeth is really fragile and comes off easily, but primarily the front 4 teeth.
It's interesting. I hadn't heard that before.
All right, so, oops, let me go back here. Oh, I jumped ahead too far. All right, that you know, frontal lobes. Okay, so these are, what I have here are some common, either co-occurring, because it's not that you have FSASD, be on the FASD continuum, or you have something else. This is why we do a comprehensive assessment, because there can be a lot of things going on. Right? You could have ARND and also reactive attachment disorder and also other things. At the same time, sometimes kids who've been prenatally exposed to alcohol are misdiagnosed. So the impulsivity and attention problems can be diagnosed as ADHD when that really isn't the cause. And they can get the best treatment for ADHD in terms of counseling and guidance and the right medications, and that's not going to be very effective. Not because the provider isn't smart or good, and not because the treatment administered wasn't good. It was because it was for the wrong. You go into your doctor now with a cough and a fever, and your doctor says, oh, gee, you must have COVID-19. Here's what we're going to do. And you don't get better because maybe it turns out you could have those same symptoms if you had lung cancer. Well, good treatment for COVID-19 is not going to help your lung cancer. Okay, so again, very important. I tell families when we're working together after I've done the assessment and we start treatment, if we don't see movement in the right direction, not fixing everything, but if we don't see things are at least beginning to head in the right direction within, say, 90 days, we really ought to revisit the assessment then, because maybe we missed something. Okay, I get very concerned or upset when I hear families that, oh yeah, we've been seeing this therapist for 4 years. Is it helping? Not really, but he likes going. I don't know. I just get more upset with the professional who at some point should have said, you know what, I don't think what I'm doing is really is really helpful. Okay. So ADHD is probably the most common one for misdiagnosis. And I don't want to spend a lot of time, but just to quickly get through this so we talk about what do you do. As I mentioned, ADHD is a disorder of the prefrontal lobes, responds well to stimulants. FASDs are primarily a limbic system disorder, and that's why they respond much better to clonidine, Tenex, and Tunub, and those kinds of medications for the impulsivity. Okay, and then very quickly, and then I want to move on to treatment. In comparing ADHD with a child who might be on the fetal alcohol spectrum disorders continuum, here are some important differences to help you sort that out. ADHD and ARND, we do see impairment in visual processing of information. So that won't help. But for kids with ADHD, they often have impaired auditory processing. We tend not to see that with kids with ARND. Kids with ADHD often have impaired ability to shift back and forth between visual and auditory stimuli. Kids with ARND, we usually don't see much of a difference or a problem with shifting between visual and auditory stimuli. So not that these let you make a differential diagnosis, but they're helpful. And when you see them, it can kind of begin to point you in one direction or another to kind of get more information to see, well, what might it be? But these are clues. Oh, maybe it's ADHD really, or oh, maybe it's really ARND that's causing the symptoms. So questions about anything we've covered so far before we jump into treatment? No? Okay. So first of all, I just want to mention protective factors. Most important, we talked about early diagnosis before age 6. That probably is the most important factor in mitigating the harmful effects of ARND. Okay? And then some other things, recognizing the disability, no violence in the home, a stable home, good quality home in those latency age years, etc. Okay, so for, I would say for adoptive parents, the real critical factors are the early diagnosis. Probably a stable home, and these other things are less of an issue, but it's the early diagnosis that's critical. Therapeutic approaches, sensory integration therapies are often needed, parent support groups, social skills training for the child, because they often miss social skills. And this often looks very similar to what you would do with the child on the autism spectrum, where you teach them, oh, when you see this on someone's face, it means that, and here's what you do, let's practice it. And, it's not quite like this, but they, they sort of learn, oh, when someone comes up and says hi, if they hold their hand out, I'm supposed to grab their hand, smile, and, go 1, 2, 3, nice to meet you. My name's Art, what's yours? And they learn subroutines like that. Okay.
What exactly is sensory integration therapy? Like occupational therapy stuff, or what do you?
Yeah, it's occupational therapy by a therapist, OT, who's trained in sensory integration. All OTs know about sensory integration. Most are not trained in it.
What does that look like?
What does it look like? Well, 2 good books for you to get. They'll give you a lot more detail. Are The Out of Sync Child and The Out of Sync Child Has Fun. And what will typically happen, at least the OTs I work with, they meet with the parents and the child, they do a whole variety of activities to do an assessment, and then they develop what they call a sensory diet. These are activities to either do in the OT's office and or to do at home to address the sensory issues. So for example, kids who have difficulty with balance, putting them on a swing, swinging them back and forth and around over time can help. Kids who have trouble with sound, may then in the course of treatment be exposed to certain sounds in a certain progressive way to mitigate that. So there are a variety of things, activities that they'll do in the OT's office, but critical is that the parent do the activities at home. And I like the book, The Out of Sync Child Has Fun, because it's broken down by sensory area. And rather than doing the same thing with your kid, every day for 6 weeks, and everybody gets bored and sick and tired of it, you can look at it, if you're dealing with, say, auditory processing or visual processing, it gives you hundreds of activities that address that area. So you can do a different activity every day to address that area. And the thing with sensory integration issues, if you follow the sensory diet, you really mitigate those issues. Okay, so that's important. Did that answer your question?
Yeah, is it directed more towards little kids, or can you do sensory integration with?
Oh no, they're teenagers that I, work with that refer. Obviously, you're going to get a better effect, and it'll be quicker if you're dealing with a 3, 4, 5, 6-year-old than if you're dealing with a 16-year-old. But nonetheless, the issues can be mitigated.
Okay, thank you. Very good, a lot of questions.
No, I was going to ask
Those are good questions. And I would, if I may, Art, I work strictly with teenagers, and I've been working with Maud LaRue, who's a good person to talk to on the board. She's on the attached board, and she's a world-renowned occupational therapist, and be happy to put you in touch with her.
Yes.
You know, about setting up a sensory room and occupational therapy interventions in our program, because it is so beneficial for kids. And I only work with adolescents.
Well, and I'm just wondering, like, how many people are trained in sensory integration therapy? Because yes, we have sensory rooms in our schools, and we have OTs in our schools, and we have OTs at the clinics, but are they really trained in the actual correct, like, sensory integration therapy? Like, from what I'm hearing from you, not everybody is trained in that. So I'm just
Right.
curious.
Most are not. In this area, I'm up north now in the Buffalo area, our metropolitan area. I think we're at about 1.5 million people. There are only 2 groups that have OTs who are trained in sensory integration. All OTs know about it, just like all primary care doctors know about hearts and livers, but that's not their specialty. So,
Okay.
you know, one clue would be if they've been trained and certified in the sensory integration praxis test. Not that that needs to be administered, but if they've had that training, yes, they know about sensory integration. You know, or the example I used before the break around stuttering. It wasn't until my son saw someone who was a specialist in that and been particularly trained in that, that everything got better really quickly. Okay, just like all psychologists know about neuropsych testing, you would want to see a board certified neuropsychologist, and actually better, a board certified pediatric neuropsychologist. And I can't tell you how many, well, I could tell you if I thought about it, I could count, but how many evaluations I say, oh, parents say, oh yeah, we already got a neuropsych here. And I look at it, and you know, it's sort of a quasi IQ educational test. I say, this is not a neuropsych testing, and look at their signature. Yes, they are a licensed psychologist. That's true, but they don't say board certified pediatric neuropsychologist. That's what you want to see. And again, in my area, there are only 2 like that.
You would say you're from North Buffalo. We have a North Buffalo in Minnesota. Are you talking New York or Minnesota?
New York.
New York, okay.
Yeah, New York. Yeah, no, I
Just so happened, you know. So.
With the accent, didn't give it away. The
Well,
New York-
I don't know.
I will say, Attach also does train occupational therapists. Maud has set up a training. So if there's some that you work with, it'd be good for them to get a hold of us, and they can, you know, we do the training as well.
Yeah, okay. I'm super interested because my TJ, my 3-year-old, does a OT. And I'm curious. It's through a big clinic, but I wonder if any of them. I doubt it. You know.
So that's where those 2 books I mentioned you might find helpful.
Yeah.
And you can just, you know, again, you could ask the OT, hey, are you familiar with this writer or these books? What do you think? And if they kind of get a blank look on your face, well, that would be a clue that maybe that's not their area of expertise.
So you're saying a 16-year-old, it's not too late for her to start OT if she's never had it?
No. Again, harder if they're older, but no. But again, sensory integration issues can be remediated with the right interventions. Okay, parent involvement is critical in working with this population. I'm not going to talk a lot about this. You're probably way familiar with it. But the main, this fellow Graf looked at a whole range of effective treatment programs. And what he summarized of is good programs have these elements. They provide structure, supervision, they keep things simple, they're steps, and everything is taught or done within context. Okay. So some strategies that are helpful, you know, yellow stickies are helpful. Focusing on what they did well, not what they didn't do, but what they did well. because that's what you want them to do more of. You know, basically people do what you pay attention to. If you start paying attention to all the negative things, you may start getting more negative things. Okay, so you want to pay attention to what you want more. Bilateral stimulation, we talked about the problems with the corpus callosum. Bilateral stimulation can help mitigate that. Again, your brain isn't static, right? It always is changing its level of integration. New pathways can develop. So bilateral stimulation. So again, with young kids, I tell parents, if you're giving your kid a bath, very simple. Wash their back this way, not this way. Simple. What else? Playing like patty cake, bilateral stimulation, games like that. Drumming, dance, martial arts, some musical instruments, piano, for example. Okay, anything that requires crossing the midline will be helpful. This is why kids on the the FASD continuum often have trouble with reading, because with reading you have to cross the midline, and that's often difficult for these kids. Okay, so bilateral stimulation. External reminders. Remember we talked about for you, because you don't have perfect memory, your external structure to compensate for that is you make a list. Same thing for kids on the FASD continuum. So here's an example of a memory card for an activity. And what I usually encourage parents to do is, whatever the issue is, first you do this with the child, and you do it a bunch of times. Then you sit down with them and you have them make up the card with you. Some kids need a lot of steps in great graphic detail, others not so much. So you make the card up, and then you do it a couple times with the child. And then at some point you give them the card and you watch them do it. Remember repetition? We talked before about how important repetition is. That's why you don't just do the card and give it to them and say, good. No, you do it with them. You make the card up with them. You do it with them with the card, then you watch them. And then ultimately you could just hand them the card and they know what to do. And as they learn to do this more and more, as you do this more and more with them, when they become older, like a teenager, for example, they'll start to do this independently. And this is how they'll learn to function more independently and live a more, independent life. So this is more for a young kid. Here's an example of a card for an older kid. Okay. Child's responsibility is to clean the living room. Instead of saying, clean up the living room, this kid needed a lot of detail, right? It's told, take the end dust, right? Spray it on a rag, wipe off. No, some kids may not need that. It may be as simple as, dust the table, shelves, and other items in the room. That may be sufficient. But this kid needed this kind of detail. Put the old newspapers in a plastic bag and put them in recycling. Take paper towel and Windex and clean all the windows. Use the sweeper to vacuum the entire rug. Okay, so this is everything he's supposed to do. And I encourage parents, put it on an index card, laminate it. If you want them to check it off like this, give them an erasable marker so they can do it. Okay. And see, for him, we have put all the cleaning supplies, brooms and vacuum away. Without that, he wouldn't do that. Not because he was being lazy, he would forget, that's all. He wouldn't remember. Recheck, very important. Once it's all done, give the card back. You can give them points, they can earn money, or sometimes just a great job is good enough. Okay. So this is how you create external structures to make up for the internal deficits, so it is no longer a barrier to their being successful. A kid, an academic accommodation, maybe a kid whose impairment causes notable difficulties with mathematics, may need and require, as part of their IEP, to be able to use a calculator. Because addition and multiplication and subtraction, it's just not something they can really do or do well. Okay? So these kinds of things are particularly helpful. The cards, I find, are wonderful for parents because, first of all, it gives you an opportunity to connect in a positive way with your child. I asked you to clean the living room. Why didn't you do it? No, you're going to do it with the kid. You do it with the kid, so now you're doing something together, right? And you can make it fun. You can make it enjoyable. And then you make up the card, but they're the ones who make it up, which gives you a chance. Oh, good job. Yeah. Oh, I see that. You think that'll work? Yeah. And you can talk about that. And then you watch them do it. And you're able to say, hey, look at that. Great job. And then eventually they can do it on their own. A couple things. Very often we want to teach habituation rather than understanding. In other words, this is what you do, the why you do it may be less important. Okay. Time management, emotional regulation, bilateral stimulation can be helpful in that. Teaching them, basic CBT things, deep breathing, guided imagery, muscle relaxation, all those can be helpful. I discussed all these rhythmic activities. Yes, singing and gymnastics. Okay. Fine motor. This would be more what your OT would do. Balancing a feather, balancing games, hand games. These are all things you can do. And then here's a bunch of resources. So you can go look at those. And I want to leave time for questions. The next set of slides talk about some programs that are evidence-based, and what they all have in common: parent education, training, and support. Okay, we're not treating the child so much as we are treating the family and helping them put in place activities and interventions that will help the child be more successful and help them feel better about themselves as parents. A second component we see in all successful evidence-based programs is explicit instructions for the children, like the card that I talked about. And third, individualized and targeted interventions. Not one size fits all, but recognizing, like I showed earlier, one card may need pictures for a young kid, an older kid, not really. And then these are some programs that are evidence-based. I'm not going to go through them in detail. If any one of them jump out at you, you could, I've got the citations here, so it's pretty easy to look them up. But these are all good programs, evidence-based, some easier to learn than others for those of you who wanted to use them. This program I particularly like, Child Friendship Training, mainly because it's time limited. And this may not be the only thing that you do or have done, but it's a great start because it's time limited. People can, put aside 12 weeks, and it does produce good results. And I like the fact that, the parent group parallels the child group. Okay. But again, the other programs are also very, are also very good. These are, again, some other programs. So, and then I've got a reference list here. So when you go online to get the slides, there are a lot of references here. Some maybe might be helpful for you. So let's use the last couple of minutes we have for questions, comments, those kinds of things. Anything I didn't cover?
I appreciate all the info and the interactiveness too. Thank you for, yes, thank you. Thank you for that.
You're welcome.
Is there anything that you feel like we should know just as parents too? I live in this all day long as a parent and a professional, and I just, I have two different lenses and they don't always match. So just, maybe you too as an adoptive dad and a provider too, just what is your best advice?
A couple things. First, I think any parent who has a child that has been prenatally exposed to alcohol, it'd be good to find a practitioner who has experience with those kinds of families. Maybe you don't see them every week, maybe you only see them a couple of times a year, but just to have, listen, you don't go see your primary care doctor every week. You don't see your dentist every week, but you've got those professionals around for when you've got questions or concerns. Same thing here. I think that would be useful. The second thing I always try to get across to parents is you don't have to be perfect. You just have to be good enough. And mistakes are fine. That's how you learn. If you're not making a mistake, it probably means you're not learning anything. When you make a mistake, you think about it, you figure out what you're going to do differently, and then you do that. So, you need to give yourself, just that permission to say, hey, I'm not perfect, and so I'm going to make mistakes, and that's fine. And frankly, in my experience, mistakes never cause a problem. It's the lack of repair that does. So, hey, I've yelled at my kids. I've at times been annoyed and, put them on a punishment that probably was over the top. And, I've just been able to go back and say, sorry about that. No, you're not grounded for the next 2 weeks. I lost my temper. Just don't do that again. Okay. It's the repair piece.
Yeah.
It's critical. So those would be some things I think that would be, important to keep in mind, both as a professional and as a parent.
May I add something there as well? And
Yeah.
you probably hear this, but that self-care piece,
Mm-hmm.
in order for your child to borrow serenity from you, you've got to be able to have that serenity yourself. And I find as clinicians, we put extra pressure on ourselves because we're supposed to know so much.
Yeah. Isn't that the truth?
When we're just humans.
I think my biggest fear is misdiagnosis, because I see it all the time. And so I'm always afraid, and with my non-biological kids, that I'm going to take them in and they're going to be misdiagnosed because of lack of information. I think that's been my fear.
Yes.
All along with, and TJ, I bring up TJ, not my other one, because I know she wasn't prenatally exposed. Her mom's got low IQ. I talk to her every day. She's a wonderful lady. She's just very developmentally delayed. So I don't worry about her as much with just prenatal exposure to anything. But my TJ, I just, his mom was in a domestic violence relationship. They were homeless. She has a history of alcohol problems. He was not positive for any other chemicals. He was born 4 pounds, only maybe a week early, so not really preterm by any means. And so she says she didn't drink, but I'm just always afraid that without that admission and the fact that, I don't see any of the facial deformity, and not that that doesn't even happen that often, but
60% of children prenatally exposed to alcohol have no facial cranial deformations.
Yep. And not that I've even trained in what that would even look like. So I guess I'm always just fearful that if I go in and say, his behavior is a little extra, that I'm just going to get a misdiagnosis that might
Well, that's why you want to go to a professional who this is their area of expertise.
Yeah, and that here in Minnesota is the University of Minnesota. That's, you know, I trust that they would do right by
But-
them. It's
but
just
what-
a fear.
Well, two things. You want to make sure that this is an area of their expertise, but second of all, that they do a comprehensive assessment, because like our children's hospital here, you know, has a whole unit for that. And sometimes parents will bring their kid there if they have a concern, and they'll come back, oh, good, there's no FAS. Well, that's true because you don't have any of the facial cranial, but there are other things going on, and they really didn't do any detailed, for instance, cognitive assessments or executive function assessments to look at those areas to see if something more subtle is going on or something completely unrelated, a mental health issue or sensory issue or something like that.
Yeah. Yep. Okay. Thank you.
You're welcome. Other questions or comments?
Not from me. I'm good. Thank you so much. Thank you.
All right.
Art, thank you so much. It's always a pleasure to be with you, even virtually.
Yeah, well, thank you all. I appreciate your participating and listening. As I say, the slides should be up there. And if you do have other questions at some point, yeah, my phone number is on the slides and my email is there. Just so you know, I do prefer telephone calls to email, unless it's a simple question. Like what was the name of that book? That would be fine. But other than that, I can talk a lot faster than I can type. So that's why my phone calls better. My son, who's a big texter, you know, at some point, like I just call him. I say, David, I'm getting tired of, you know, time. All right. Have a good rest of the day, everybody.
You too. Thank you.
Thanks, Art.
Take
Hey,
care.
I owe you dinner next time we're together.
Yep. So maybe next year at Attach.
Yeah, here's hoping so. See you in California.
Great. Take care. Bye-bye now.
Bye-bye.
Thank you so much.
Thanks, you guys.
Good.